And we have next is inhibitors of angiotensin or angiotensin inhibitors. So first we have the ACE inhibitors, angiotensin converting enzyme inhibitors. So these are antihypertensive drugs that can lower the cardiovascular risk, reduce the mortality and morbidity in hypertensives, and also those at high cardiovascular risk. So they are more effective in preventing coronary artery disease, CAD, in patients with hypertension. And generally, generally speaking, they are well tolerated. And the good thing is they do not have any problems. They do not cause any problems with lipid and glucose metabolism. So they have a good safety profile. And they also have been shown to reduce the mortality and morbidity in patients with congestive cardiac failure, CCF, and patients post-myocardial infarction with reduced left ventricular ejection fraction. Okay, so patients, some of them have reduced left ventricular ejection fraction after myocardial infarction. Of course, when you have myocardial infarction, sometimes certain parts of the heart becomes less functioning. Okay, like in this case, if you have the left ventricular ejection fraction, which is reduced because of necrosis of certain parts in the heart in the left ventricle. So this is where ACE inhibitors is useful. And in patients with established vascular disease but normal left ventricular function, ACE inhibitors reduce mortality, myocardial infarction, reduce stroke, and also new onset congestive cardiac failure. So this is basically the selling points for why we should use ACE inhibitors. In the diabetic patients, ACE inhibitors have been shown to reduce cardiovascular mortality, and they have been shown to prevent the onset of microalbuminuria. Okay, so microalbuminuria is one of the things that we look at and to look for kidney problems, which can be an effect of hypertension. Okay, long-standing hypertension, of course, can cause problems with the kidney. Okay, so it reduces proteinuria and also slow down the progression of diabetic and non-diabetic renal disease. Okay, so which is a very good thing. Okay, protects our kidney. Okay, ACE inhibitors protects our kidney in patients. So this is a diagram, okay, showing the sites of action of drugs that interfere with the renin, angiotensin, and aldosterone system. Okay, so we have this system here. We have kininogen, bradykinin, and active metabolites. Okay, bradykinin causes increase in prostaglandin synthesis. So when you have bradykinin, you have prostaglandin increase causes vasodilation. So decrease in peripheral vascular resistance and also decreased blood pressure. Okay, so this is one thing here. And then we have angiotensinogen being converted by renin to angiotensin 1 and angiotensin 2 causes vasoconstriction, okay, and also causes aldosterone secretion. So vasoconstriction will increase the peripheral vascular resistance, which will increase the blood pressure, okay, and also aldosterone secretion will increase the sodium and water retention. Okay, we have sodium and also water retention. So these will of course, increase the stroke volume, increasing the cardiac output, increasing the blood pressure. Okay, so these are where the drugs come in. So ACE, so we have the ACE inhibitors, okay, blocking here. So ACE converts angiotensin 1 to angiotensin 2 and bradykinin to inactive metabolites. So ACE comes here to block this so that you don't have increase in blood pressure. Angiotensin receptor blockers, ARBs, say like losartan, etc., will block vasoconstriction, block aldosterone secretion, block preventing increase in blood pressure, and also spironolactone, epinephrine. So these are diuretics that will prevent the sodium water retention and also prevent subsequently increase in blood pressure. So we can have, when taking these drugs, we might have cough. Okay, rarely you can have this severe life-threatening condition, which is angioedema. Okay, so I know. So this is one of the things that we sometimes have to look for in drugs. Okay, even in our recent COVID vaccines like the one produced by Pfizer, Comirnaty, etc. So these are all we will always look for angioedema in these patients. Reduction in the renal function, okay, may occur in patients with renal vascular disease or renal impairment. So serum creatinine and potassium needs to be checked, okay, before the commencement, before we start using angiotensin blocking agents, okay, so that we want to know the baseline of our kidney function. And also after 2 weeks after starting, within 2 weeks after starting the drugs, okay, maybe after 1 week or maybe after 10 days, okay, so you check again this creatinine and potassium. We want to know what's happening when we start the angiotensin blockers. So if there is hyperkalemia, for example, the breathing is more than 5.6 millimoles per liter, or a persistent rise of serum creatinine of more than 30% from baseline within 2 months, then we have to reduce the dose of ACE inhibitors, or we should discontinue, we should stop the ACE inhibitors. Okay. Because ACE inhibitors, these drugs may increase fetal and also neonatal mortality, can cause death. So therefore, these drugs are contraindicated in pregnancy and breastfeeding. Okay, remember this. Okay, we don't give ACE inhibitors to pregnant mothers. We don't give ACE inhibitors, ARBs, to breastfeeding mothers. Okay. Counseling should be given to women of childbearing age before initiation of RAS blockers. Okay. So before we want to give patients RAS blockers, we have to counsel the patients about this. Okay, and patients who become pregnant should seek immediate medical advice. Okay, with by seeing their doctors or obstetricians, etc. And then we have angiotensin receptor blockers. Okay, like candesartan, irbesartan, losartan, telmisartan, valsartan, olmesartan. Okay. So these are angiotensin receptor blockers. Okay, angiotensin receptor blockers. So they act here, prevent vasoconstriction, prevent aldosterone secretion. Okay, so these specifically block angiotensin 2 receptors. One advantage of ARBs over ACE inhibitors is they cause less persistent dry cough. Okay, they do not cause as much persistent dry cough as ACE inhibitors. Okay, ARBs. So so these drugs can be an alternative. Okay, for patients who are not tolerant to ACE inhibitors. ARBs have been shown to prevent progression of diabetic nephropathy. Okay, so when you have diabetes, the diabetes may cause problems with the kidney nephropathy. So ARBs have been shown to reduce that progression. Okay, and also may reduce the incidence of major cardiac events in patients with heart failure, in patients with hypertensive left ventricular hypertrophy, and also diastolic heart failure. And these drugs may reduce the cardiovascular events, including the risk of myocardial infarction. Okay. So this is just the pharmacokinetic characteristics of and dosage of selected oral antihypertensive drugs. So these are the drugs that encompasses that covers all kinds of groups. So for example, amlodipine is of course a calcium channel blocker. So the half-life is 35 hours. The bioavailability is 65%. Do we need to reduce the dose in moderate renal insufficiency? No. Okay. Atenolol, okay, beta blocker. So we need to reduce the dose in patients with moderate renal insufficiency. Okay, where the creatinine clearance is more than 30 millimoles per minute. Okay, so this of course this slide is got nothing to do specifically with it's not specific about the angiotensin blockers, but it's in general. Okay, so captopril, okay, ACE inhibitor, clonidine, okay, diltiazem, CCB, hydrolazine, vasodilator, hydrochlorothiazide, which is a thiazide, which is a diuretic. Okay, so and various drugs. So it's important to try, if possible, we try to remember which ones we need to adjust the dose. Okay, so the ones most notable are lisinopril, okay, clonidine, captopril, atenolol. So these drugs, especially these two, we need to reduce the dose in patients with compromised kidney function. Okay, I think that is all for this topic.